Hi, this is Nicole Neal, and today we're going to be talking about aplastic anemia. Aplastic anemia, also known as AA, is actually a bone marrow failure disorder that is caused by the lymphatic destruction of early hematopoietic cells. In AA, the body stops producing enough new blood cells, which leads to symptomology of fatigue, the patient being more prone to infections, as well as uncontrolled bleeding. This is a rare, life-threatening, immune-mediated disorder that affects patients of all ages. Additionally, the peak of this disease process occurs in mid to late childhood, as well as in the elderly. The estimated annual incidence of AA is about 2 cases per every million people in Europe and North America. And among those, about 10% of patients have a history of non-viral hepatitis that precedes the onset. Aplastic anemia can be seen as inherited or acquired, though acquired aplastic anemia is much more common. Additionally, there are several environmental factors such as drugs, chemicals, radiation, and different viruses that have been found to be triggers for the immune system to begin attacking, which can then lead to aplastic anemia. However, the cause of aplastic anemia usually cannot be identified, which is why it is sometimes called idiopathic aplastic anemia. When it comes to classification, classifying aplastic anemia is dependent upon the number of blood cells that show up on the blood tests and the bone marrow biopsy. The classifications include moderate, MAA, severe, SAA, and very severe aplastic anemia, VSAA. In the majority of cases, aplastic anemia is an immune-mediated disease with T lymphocyte as the effector and hematopoietic stem and progenitor cells as the target. The immune element of this disease process is well accepted due to the responsiveness of aplastic anemia to immunosuppressive therapies. Furthermore, the majority of patients show hematologic improvement after T-cell depletion by anti-thymocyte globulins known as ATGs. In simpler terms, and as previously stated on the last slide, aplastic anemia is due to activated T-cell destruction of the bone marrow. However, why exactly T-cells are activated to attack marrow is still unclear. Acquired AA usually consists of an antigen-driven recruitment of cytotoxic and helper T lymphocytes for the immune-mediated destruction of hematopoietic stem cells. The killing of these stem cells also occurs due to a consequence of inflammation cytokine-induced apoptosis. AA is sometimes a disease process in which patients can be asymptomatic, but when these symptoms are present, the signs and symptoms include fatigue, shortness of breath, rapid or irregular heart rate, pallor, recurring infections, unexplained or easy bruising, nosebleeds, bleeding gums, prolonged bleeding, dizziness, headache, and a fever. From that list, the most common symptoms are fatigue, easy bruising or bleeding, and infections. For patients not presenting with these subjective symptoms, AA should be suspected in patients that present with pancytopenia and hypocellular bone marrow. When AA is suspected in a patient, a comprehensive evaluation should be performed quickly in order to exclude other conditions that may mimic the symptomology and presentation. This baseline evaluation should include a history, physical exams, labs of CBC with diff, and a reticulocyte count, and a bone marrow aspirate with a core biopsy. This search should focus on the elimination of drugs or toxin exposure and autoimmune diseases. This is so important because the course of treatment is guided by the diagnosis. Throughout the diagnosis of this disease and the treatment process, patients need to be provided a strong amount of supportive care. This is a difficult disease process to diagnose and requires a multitude of different testing, including major blood tests and a possible bone marrow biopsy. One of the roles of the advanced practice nurse is careful observation, watching for a need for blood transfusions, medications, or a possible bone marrow transplant, as previously stated, if the AA becomes severe enough. Some of the treatments for severe AA include a stem cell transplant, immunosuppressants, bone marrow stimulants, antivirals, and antibiotics. During any of these treatment regimens, the patient of the Christian advanced practice nurse will need a strong amount of education regarding why testing is being done and the ways in which the disease process works on a biological level in order to foster patient understanding, which will aid in the patient's self-care and willingness to participate in treatment in the future. Furthermore, the role of the Christian advanced practice nurse is to foster an environment that is open, calming, and embedded in the Christian values of compassion and empathy. It is important for the Christian advanced practice nurse, to remind themselves that while their degree requires them to diagnose, that their calling from God requires them to put just as much time and care into providing patient-centered education and health care. Considering this is a disease process that has the potential to be lethal, fostering an environment of care that is heavy in Christian values of patience and kindness is essential for successful care moving forward. As said in Luke 6:40, the student is not above the teacher, but everyone who is fully trained will be like their teacher. It is important to view a patient as a member of their own healthcare team. This is not to say that patients are licensed or capable of providing acute care and treatment for themselves, but more so that cultivating a non-judgmental, caring, patient, and educational environment for the patient and taking the time to make sure the patient has adequate understanding of their disease process is of utmost importance and will lead to an increase in their symptomology and their self-care in the future. And this is the reference page. I hope that you guys enjoyed my presentation on aplastic anemia and that you learned something, hopefully. So I'm going to go ahead and watch your presentations. I hope that you guys have a great week.